So happy to have you here today for our fourth and final finalist Zoom webinar featuring our new HR innovation and our new health application of AI categories. My name is Melissa Faulkner. I'm the Executive Marketing Director here at UCSF Health Hub, and our host for today is Mark Goldstein, our Chairman and our Executive Producer.
Hi, all. This is the fourth of four, and the last three have gone really well. Again, I'm Mark Goldstein. I'm a volunteer at UCSF Health Hub, and everything we're doing for the awards. My day job is I'm a venture capitalist at a firm called Builders, and I love investing in great healthcare and health-related companies, and we've got tons of them today. Today's session is really about getting a final taste of our finalists. We have two categories of finalists. We have our best of class, which are more mature companies, and our rising stars, which are companies that have started more recently that are making incredible traction. Today, we're going to have two different sessions, one of which is called a New Health Application of AI, which is the first award we're going to be talking about. That will go through basically the best of class, and then we're going to go through the rising stars, and then we're going to go through the new EHR innovation. My role is MC. It's all about hearing the companies shine. And the way we're going to do this in a format is the companies get 30 seconds to basically tell everyone who they are, what they're all about. And then I'm going to throw them a bunch of questions. And with that, we're going to jump right into the companies. And the first company up is Rad AI.
Hi, I'm Jeff Chang, ER MSK radiologist, co-founder of Rad AI. I started college young at age 13, med school at NYU at age 16, was the second youngest doc on record in the US. We founded Rad AI really to reduce radiologist burnout and improve the quality of patient care, automating workflow for both radiology groups and health systems. So our first solution, Omni, automatically generates the impressions of radiology reports customized to each individual radiologist's language, and it's embedded into existing workflow as a zero-click solution. This reduces the number of words that radiologists have to dictate manually by about 30 to 35%, reduces fatigue and burnout, and saves radiologists about an average of an hour per 9-hour shift. So we're now working commercially with 8 of the 10 largest private radiology groups in the country and nearly 60 radiology groups overall, so comprising more than 20% of all active radiologists in the US. And our second product does automated follow-up care coordination for patients. And so that really helps with ensuring that cancers are caught and treated early and reducing the overall cost of care.
Excellent. Great job, Jeff. Up next is Clearly, and it's James Min. James, take it away.
Great. Thanks so much, Mark. So I'm Jim Min. I'm a cardiologist by training, spent about 15 years working at New York Presbyterian Hospital and Weill Cornell Medical College on the Upper East Side of Manhattan, where the nidus and the idea of Clearly came about. At Clearly, our company is focused on coronary heart disease, which is the cause of heart attacks and premature sudden coronary death. It represents the #1 public health epidemic. It's the #1 cause of mortality. It's the #1 cause of morbidity, and it's the #1 cost to the healthcare system. And at Clearly, we've leveraged machine intelligence to create a comprehensive standardized digital healthcare management platform to deliver precision heart care or personalized heart care to support physicians and patients in preventing heart attacks. Our precision heart care platform performs whole heart disease phenotyping of coronary heart disease using advanced non-invasive imaging. And we've developed subsequent translational tools so that we can touch all stakeholders across the care continuum, including the imager, the specialist, the generalist, and even the patient. And we believe that an early and a personalized approach to cardiovascular disease prevention using these AI-enabled techniques really holds the potential to save millions of lives per year. Thank you.
Great. Excellent. Thanks, James. Next up is Immune AI and Drausen Wilson. Are you with us?
Yep, I'm here.
Great. Bring it on.
Everyone, I'm Drausen Wilson. I'm the director of machine learning at Immune AI, which is an immune system-focused biotech company, leveraging very large clinical cohorts of single-cell immune profiling from both blood and the tumor microenvironment. And what we do is we extract clinical signatures and biomarkers, as well as target discovery insights from these large clinical cohorts of biological samples using basically cutting edge single cell technology along with the AI that interprets all of this data that we generate from it. And then we take those initial leads and we interrogate them using our functional genomics platform, where we sort of do a bunch of functional perturbations, both knockout experiments and drugs, to further winnow down the set of targets. And ultimately, we have a number of active therapeutic programs that are pretty early stage. We're about 4 years old. And we are focusing right now on oncology and autoimmunity indications.
Excellent. That's great. Next up from Alio is David. David, take it away.
Hi, everyone. My name is Ava Lim from Alio. I'm filling in for Dave today, our CEO. He's currently on a plane traveling to an investor meeting. So Alio, we are a remote patient monitoring platform. Our mission is to provide peace of mind for patients on dialysis and to prevent hospitalizations and provide cost savings to the health system. Our platform consists of 3 parts. It's an FDA-cleared system consisting of a smart patch, the hub, and the provider portal. The smart patch is non-invasive, wireless, and it requires 0 calibration, and it collects basic vitals in addition to hemoglobin, hematocrit, and potassium. And the hub, which sits in the home, collects the data, the raw data off of the patient from the patch, and then sends it up to the cloud where our AI and algorithms will transform it into clinically actionable metrics for the providers to use. And that's all provided on a dashboard for the providers and doctors to look, and also sends notifications when a patient requires attention and there could be possible complications.
Great. Well, you've done an amazing job filling in. Thanks. Okay, so I get to have some fun here and throw some questions at people. I'm going to first question is going to go to you, Jeff. Let's talk about cost savings. What do you know about your cost savings? And today that's what hospitals are increasingly caring about. And what's your story there?
Sure. So our second product, Continuity, automatically, as I started to mention, automates follow-up care coordination for patients. So it makes sure that for incidental findings, patients get appropriate follow-up. That includes whether it's pulmonary nodules, liver lesions, abdominal aortic aneurysms, thyroid nodules, ovarian lesions. These often need to be followed up in 3 months, 6 months, a year, because they could all turn out to be cancer, or the aneurysm could have been large and will need surgical intervention. But so many of these incidental findings are never followed up on. The study was performed for some other reason. The ER doc, the hospitalist, the specialist may not notice that it was mentioned in the report. The radiologist may have forgotten to mention it in the impression, or didn't include a follow-up recommendation. And so then the patient comes back a few years later with metastatic disease and much higher morbidity and mortality. So by ensuring that these incidental findings are tracked and followed up, we can help ensure that these cancers are caught and treated early, that the aneurysms are treated before they rupture. And so this markedly reduces the overall cost of care. It's a lot less expensive to our overall healthcare system to be able to treat an early stage cancer than it is to treat diffuse metastatic disease. It's also a vast improvement in the quality of patient care and also reduces health system and provider.
And Jeff, do you have any hard numbers yet?
Sure. Yeah, so one of the large health systems we work with, RadAI Continuity, has actually already helped them catch more than 50 definite new cancers on reports from imaging done in the ER. So where the incidental new cancer wasn't noticed by the ER team, it was never mentioned in the notes or the discharge summary. And so without continuity, none of these cancers would have been caught and treated early. So it has this massive impact, both for definite new cancers and also for potential cancers. Of course, it also drives additional revenue for the health system.
Okay, that's great. James, I'm going to run right back to you, and I'm going to make it easy, give you the same question. Focus on, tell me about, do you have any numbers? What I'd really love to hear was, again, what we heard from Jeff, the 50 cases. What do you got? What can you share?
Yeah, I mean, so we believe that delivering precision heart care will reduce total costs of care. And we published a couple of peer-reviewed publications based on multi-center trials, focusing on both a symptomatic population and then more recently on the asymptomatic population. In the symptomatic population, I'll give you a few staggering statistics. About 2/3 of the people who go for an invasive coronary angiogram are not found to have actionable coronary disease. And over 90% of stress tests performed across the country for evaluation of heart disease are considered normal. So we're not doing a great job selecting people who should undergo these advanced tests and these invasive tests that come with not only high cost, but potential harm. So we published a couple of studies in multi-center trials that demonstrated that by use of a precision heart care platform that's driven by machine intelligence, you can pinpoint individuals with much greater precision and reduce those unnecessary tests to save the overall healthcare system somewhere between 30 and 50%, depending on the test that you're choosing. even in the asymptomatic population, we have a couple of large self-insured employers as clients. And what we've demonstrated in an employer benefits program for cardiovascular screening, that we see near-term savings in patients who get better preventive measures that actually not only saves the money for the employer, but also
And have you quantified those savings at all?
It's not a huge ROI in the near term, but it's about 1.5, 1.6 our net ROI, even after taking into account our ASP. And then the long-term savings of reduced heart attack rates, reduced ensuing heart failure, and reduced death, will add to that ROI. But as you know, Mark, oftentimes we're fairly short-sighted in a 2-year or 1-year window. But even within that 1-2 year window, we can make the employer more, save the employer more money by doing preventive screening measures.
So I'm going to stick with this question. Drasen, you get to go, and let's talk about specific numbers, if you have any, about the results. I love the 1.6 net ROI story, the 50 new patients. What can you share?
Yeah, so unfortunately, as a biotech company, we have a sort of slightly longer timescales in what we're trying to do, which is develop new therapies. So what we do know is that 90% of all drugs fail in clinical trial, and the natural question is why. And Immuni's hypothesis, which we have yet to validate, but this is our big hypothesis as we're stating, is that one of the biggest reasons that they fail is because all preclinical screening happens in really artificial in vitro and mouse models. And so one of Immuni's biggest focuses is on improving the preclinical IND-enabling screening process through using vast collections of patient cohort data, like real samples, and also improving basically the in vitro conditions in which we do these experiments to make them much more like what's going on in a human tumor. So I wish I could tell you sort of the amount of money or patients that we've helped today, but I think in about 5 years we'll know this. But what I can tell you is the number we're trying to close, which is go from maybe 10% clinical trial success to something double or triple that. And
so that's your thesis and your superpower, is that basically you can 2 or 3x clinical trial success.
That's right. So the idea is, we're building the ship in the dry dock, and then once we sort of launch it out to sea of clinical trial, it's going to be much more seaworthy than the other ships that people build.
Okay. Ava, let's talk about Elio and question you. Tell me about your superpower. What would you describe it to be?
Sure. Our superpower, I think, would be that we're able to capture a lot of the metrics, and it's coming from just one device, this Elio Smart Patch. So we're all in one. We can do the heart rate, skin temperature, auscultation, hemoglobin, hematocrit, and potassium, with additional metrics such as sodium, creatinine, and urea coming down the pipeline. And so I think this enables providers to triage patients better, and also provide more efficient and personalized care for the patients in and out of the clinic setting, and prevent them from coming into the ER or the hospital, because we're able to, with the continuous monitoring, we're able to catch the complications before they turn serious or life-threatening. And instead, they can be resolved with much more simple procedures.
And do you have hard data right now?
Not on the Elio Smart Patch. We're actually designed, so we submitted for our second clearance on the H&H and potassium. So that was kind of our priority. And our next priority is to design a study looking at the health economics and getting the hard numbers on what we're able to prevent and the cost savings to the health system.
Okay, fair enough. Hey, I'm going to jump right back to, got a few more minutes here, so throw a few more questions, and Jeff, we'll just come back to you. Your superpower. What is your superpower? If you're in a sea of amazing other AI companies that are all very niche focused the way you are, tell me that superpower.
Sure. So Red AI Omni is built specifically by radiologists for radiologists. It embeds seamlessly into existing workflow as a zero-click solution. There was a radiologist leader at one of the largest practices in the country that noted that when we deployed another best-in-class solution, it took our radiologists about a year to get used to the product in their workflow. For Red AI Omni, it took most radiologists a day. There's currently no competitors for Red AI Omni. We have by far the largest data set of historical reports among startups, over 175 million reports. And we continue to improve each radiologist's language customization based on their edits to impressions. So building a
So
proprietary data set.
So speed is it. Speed. You're like
To some extent, yeah. But also having that massive data set, continuing to improve the product really rapidly, and then also applying to a much larger, broad spectrum of cases than anything else, right? Because we as radiologists spend 75–80% of our time dictating reports. So that's our main end product, what our ordering clinicians see and read. Yet almost every AI startup in radiology focuses on the images, which is just a small subset of use cases for each startup, whereas we apply to every report, every modality. And each of our follow-up products, which also have direct synergies, also apply to every report, every modality. And so that allows us to have a much bigger impact across all of healthcare, because radiology ties into each of the different subspecialties. And that's what really makes it have a much bigger impact.
Good. Well, James, I'm going to throw the same question at you. Let's talk about that superpower and, again, against your comps.
Sure. Like, so our superpower, we measure heart disease. And I know that sounds silly because you'd say, well, don't all heart doctors measure heart disease? Turns out for the last 70, 80 years, we've never actually measured heart disease. What we've done is we've measured upstream risk factors of heart disease or downstream sequelae of heart disease to evaluate symptoms, but we've never focused on the atherosclerosis itself that builds up. It's the plaque that builds up within the walls of the artery silently over the course of many decades. By personalizing the care and measuring actual heart disease, we can get the right patient to the right test, to the right treatment at the right time. And, I'd like to say that we invented something, but we actually didn't. 10 years ago, when we started a clinical cardiovascular disease prevention program that served as the nidus or the idea for Clearly, we just looked around at the world's most successful preventive care paradigms, and they were all in cancer prevention. So when we looked at a mammogram or a colonoscopy or a lung CT scan to prevent lung cancer deaths, colon cancer deaths, or breast cancer deaths, we started to ask ourselves the question of why do we use advanced non-invasive imaging for direct visualization of disease to prevent the most common cause of cancer, but not the most common cause of death? And that was with the idea of to leverage advanced imaging, to do non-invasive imaging, to do whole heart comprehensive phenotyping, to really provide precision heart care.
Okay, great. And Ava, I'm going to come back to you, switch it up a little bit. We talk, I know you're coming to market with your device, but tell me why a provider should basically sweep away some of their old processes and systems and start working with you guys.
I think one, because we're all in one, we have shown the ability of our AI platform to determine the world's first non-invasive metric, in addition to additional metrics all in one. I think as it provides cost savings, but also we're working to empower patients to take back control of their chronic conditions and to live a life that's not overcome by their condition, and to deliver a peace of mind. And then delivering that peace of mind when they're out of the hospital and out of the clinic is our mission. And I think, with the
so you're saying you replace multiple solutions, point-based solutions with one device effectively.
Yes.
Okay, so you're simplifying things in a way that, that's awesome. Okay, cool. Sorry to interrupt, but that sounds great. And so last one, and Drew, let's talk about, I know it's early, but what didn't you cover when you talk about, again, about your superpower a little bit?
Yeah. So our superpower, we have two superpowers: data, people. So the data we have is the best single centralized atlas of data. We call it AMICA, for annotated multi-omic immune cell atlas. So it's the best atlas that we're aware of in the world. It comprises hundreds of millions of individual readouts across tens of millions of cells, from both proprietary cohorts that Immunite self processes, and also basically any paper that is published using single cell RNA-seq or bulk RNA-seq. We have processes that ingest this data into our centralized database. Furthermore, we can generate our own internal data from our in vitro experiments. And that data is incredibly high modality. It is very, very wide and large, and it allows us to sort of interrogate basically new biology. So data is number one, and people are number two. because we're a startup. We're going up against the big pharma players. They have less data than we have, but they have a lot more people. But the people are balkanized into little silos, right?
Yep.
And so our people, our team of scientists and engineers work really.
Okay. Now going back to those four best-in-class companies, 4 great companies. All you guys are winners. Best of luck to you. I really appreciate your being on, and I'll see you in Las Vegas.
Thank you.
Thank you.
So with that, as you know, we're now going to go to our Rising Star class. These are companies that are a little earlier on in the process. Earlier on, meaning maybe they've just been around 2 or 3 years. Maybe they haven't raised as much money. Doesn't mean they're not as incredible, impressive, crazy as those last 4 companies we saw. We decided to create a new category called Rising Star. We have 7 rising stars, and the way this is going to work is each of them are going to get 30 seconds, and then I'm going to basically send out a few questions across the board. And with that, we're going to start with Manuel from Idavan.
Doesn't look like he is on at the moment.
Okay, so we'll move right on to Sanjay. Are you on from Waymark?
I'm here. Thank you.
Excellent. Great.
Apologies for my voice. I'm a dad, so I caught whatever my little kids have. So Waymark's a public benefit company. We serve the 1 in 4 Americans on Medicaid. They're hard to care for due to social barriers to good health, like inadequate housing and food, and high prevalence of mental illness and substance abuse. And primary care physicians have a hard time caring for them. Few accept Medicaid insurance due to inadequate fee-for-service payments. So we solved that problem by taking population-level funding to cover an entire community's health. And then we train and deploy for free to patients and PCPs. Pharmacists who titrate meds between visits, offload providers from their prior authorizations, a big cause of burnout. Therapists who provide mental illness and substance use, and community health workers, people trained from the neighborhood to help with services like housing, food, finding patients where they are, under the bridge, in a shelter, wherever. Our machine learning focuses on deploying those people to the right patients at the right time with the right intervention. For example, combining data on food support programs with data on our patients with diabetes helped us discover that people on insulin tend to spike in their hypoglycemia ER visits towards the end of every month. Food stamps are delivered at the beginning of the month, so people are taking the same amount of insulin but having less food towards the end. That helps us direct our social workers in a targeted way to provide food voucher programs, our pharmacists to readjust insulin and help people with glucometers towards the end. We do the same for smoke inhalation from wildfires and early asthma refills, and also help people choose the right medication for themselves between visits with randomized trial data.
That's
our superpower is really deep knowledge of this underserved population and helping do more face-to-face time.
Fantastic. Thanks, Sanjay. Perceive AI, Christian, are you there?
Hi, Mark. Yeah, pleasure to be here. Christian Densero, I'm the CEO and co-founder of Perceive AI. We are a precision medicine company. We have a platform called Foresight, that is forecasting disease progression using multimodal data. Our main focus is in neuro and in Alzheimer's disease. In particular, we forecast cognitive decline. Our goal is really to increase the success rates of clinical trials by selecting the right individuals for these trials. We've shown that we can reduce up to 50% the size of a trial while maintaining the same power, and also to empower clinicians into timelier diagnosis. So I'm probably going to go a bit over that portion, but clinicians basically don't diagnose a disease early enough for optimal treatment. And we think that by providing forecast and prognosis information, we can actually empower them to take action right away.
Fantastic. That's great. Next up, Neurogly. Anit, are you there?
Yes, I'm here. Hey, everyone. This is Aniket Singh, founder and CEO of Neurogly Therapeutics. Neurogly really started with the dream to reimagine the entire care for patients suffering with neurological conditions and improve outcomes, not only for just the patients, but also for the family members and the loved ones who are caring for these patients. So we are a technology-first care delivery company where we are offering virtual neurology specialty care. And at Neurogly, we have built a platform which really leverages a suite of non-pharmacotherapy interventions and digital biomarkers and our expert clinical care team to really provide personalized care to the patients. And this platform is really guided by our Neurify Analytics engine, which is really focusing on collecting a ton of digital biomarkers, both active and passive, and trying to really learn from the user's behavior. So that way we can titrate not only just the frequency of the therapy, but also the intensity of the therapy and personalize the intervention, moving the needle from one size fits all to finding the best therapeutic fit for that patient. Today, Neurogly offers a scalable and evidence-based at-home cognitive care program, and we've just gone live with Nuance Health in New York and Connecticut. Thank you.
Oh, congratulations. That sounds great. Next up, Mark Shapiro from XCures.
He's not on with us at the moment.
Okay. Josh from Bayesian Health.
Hi, this is Suchi Saria. I'm the founder CEO of Bayesian Health. I want to first start by apologizing for being obnoxious and interfering in that previous session, but excited to be here. So what does Bayesian do? So Bayesian offers a platform for doing intelligent point of care augmentation for health systems. Essentially, it's like making the EMR smarter, dynamic, more predictive, more proactive. It integrates diverse multimodal data from labs, structured and unstructured data from labs, vitals, notes, et cetera, just both from this encounter and past encounters to identify patients at risk for declining trajectories, signals, flags patients, identifies them, surfaces within workflow for clinicians like the care team, physicians, nurses, case managers within the EMR and within within workflow, both inside and outside the EMR, to make it really easy for them to evaluate the clinical signal, identify, diagnose, and then supports them into doing the right, administering the right timely treatment and document. In terms of clinical benefit, as an example, a lot of clinical areas we tackle are all around areas where hospitals today are penalized. And there's massive clinical and financial benefit to be had from a margin perspective, documentation perspective, from better clinical documentation, better margin and care. So one example is sepsis, leading cause of hospital deaths. I lost my nephew to sepsis. I've worked in the field of machine learning AI for 20 years, 14 in healthcare, and specifically in sepsis, wrote one of the earliest papers showing early identification of sepsis using ML can save lives. We published earlier this year, Bayesian published 3 papers, manuscripts that were featured on the cover of Nature Medicine, the only platform to show very, very large studies showing 20% reductions in mortality. And this was from implementing at a system like Johns Hopkins that was already in the 85th percentile from an outcome perspective. And we showed 3 really big and breakthrough results for the field. One was 20% reduction in mortality. The second was 89% provider adoption over a period of 3 years. Generally, providers don't want to adopt any tools. And these studies, these results were sort of very separated from anything we've seen before in the field.
Great. Thank you. And you were not obnoxious. I know obnoxious and you were not. So next up is Stuart. I know you're there from Biome Analytics.
Well, thank you for having us here. I'm the founder of Biome Analytics. We're a self-funded startup, and our mission is to cut the cost of acute cardiovascular care by $500 million in the next 36 months, and ensure that about 200,000 patients are impacted by the quality improvement initiatives we drive. Today, we're about 20% of our way to that goal. And just in the Bay Area, a few miles from you, we have delivered 8-figure savings to 2 of the health systems, including the UC health system. So we build a network of applications, machine learning driven applications that consume hospital cost and clinical data. We identify high impact opportunities by comparing them to a very substantial benchmarking database that we've built, probably one of the biggest in the US of both cost and quality data directly from the hospitals. And we've run a number of improvement initiatives, and our clients can choose from a library, the one that makes most sense to them. Today, we serve about 50 hospitals and are used by 40% of the top 10 heart centers in the US.
Wow, that's great. Okay. So quickly, did Manuel or did Mark join us?
We have Manuel.
Okay, Manuel, here you go. Manuel from Idavan. Let's hear this. Let's hear the 30-second pitch.
Thank you very much. Sorry for the connection troubles before that. So we are Idavan. I'm founder and CEO at Idavan. We were born to reduce cardiovascular disease and sudden cardiac death. And we are doing it by automating what cardiologists are doing when dealing with electrocardiograms. Electrocardiograms and ECGs are the entry point of any cardiac medical checkup. Anytime a heart is checked, an ECG is performed. And this is a signal, and we have been doing R&D for more than 12 years now and published more than 30 papers to demonstrate that we can automate what doctors are doing. It's more than 1 million hours of doctors spend every single day dealing with electrocardiograms. And I'm a cardiologist. I have suffered that pain every single day of my life. And I know that at scale, this can add a lot of value to the world. That's why we decided to build a solution, which is called Willem. Willem is to honor Willem Einthoven. He was the father of the electrocardiogram. And we are today, we have an edge. We are on the best position to do that. We are automating 86 cardiac patterns, which means we are automating the diagnosis of the diseases affecting 90% of the global population. And this is the entry point. That's the first complementary test in the world, no matter if you are reaching a cardiologist, a general practitioner, or any kind of doctor that has to check the ECG. Our business model is really simple. It's a B2B SaaS model. Engagement is high and is growing really fast because it's just based on the software. We are integrating with any hardware that is out there reaching patients, any sensor that is performing ECGs out there, from the ones that have been out the hospital for the last 20 years to the new ones, wearables and smartwatches. We are being able to integrate with all of them and standardize the way those ECGs are tracked at scale. We are growing really fast, and we are now getting data or pipeline data from patients in the 5 continents. So last month, we were able to reach Australia, which was the last continent to be reached. Thank you.
Excellent. Great. Thank you. First question I'm going to put out there, and I'm not going to ask anyone specifically. Yes.
Sorry to be obnoxious, if that's the word.
You're here. Go. Okay. Bring it on. That's so here you let's hear your story.
Cool. I'm Sujanya with Genie Life Sciences. Thank you for the opportunity to present here. We are a clinical stage phase 2 ready company, and we have a multi-target AI platform that we've built, and we super accelerate novel therapy for rare and inflammatory diseases. There are about 7,000 rare diseases, and less than 5% of them have any cures. So obviously a large addressable market, patients and families who suffer. The enabling science and technology that we have developed is a next generation kinase immunomodulators, which is differentiated from previous generation, which were much more immunosuppressants. And what we have is a P38 alpha MK2 and ERK12 pathway is what we leverage. We built the AI machine learning platform, which is an end-to-end drug development platform. So we don't stop just at discovery. We take it all the way. We've developed now 21 plus novel immunomodulators. We have the lead compound, and the first indication is for ARDS, acute respiratory distress syndrome. We have completed a phase 1 study in 48 people, dosing SAD and MAD, single ascending dose, multiple ascending dose. And we are now phase 2 ready, hoping this winter we will actually dose patients here in the US. And since we've applied, actually, we already have a second and third indication as well, which is in the pulmonary and autoimmune area. And everything that we've just mentioned to you, we've accomplished in the last 2.5 years with less than $8 million spent.
Awesome. Great. Thank you. And sorry about that miss. So I'm going to throw some questions. This is only for folks that are in market and have some of this data. Who wants to talk about how quickly they can go live? Because this is the primary concern I'm hearing about all new health applications of AI at provider sites is how long does it take for me to basically get this live and to, how quickly can I basically show some results? Who wants to run with that?
Take it 2 weeks from the time we get data from our clients. It's never easy to get data from our clients, but within 2 weeks we can deliver. Our clients start understanding where their opportunities are and how to improve.
And so I'll drill down on that a little bit, Stuart.
Yeah.
What opportunities, what can they find out in 2 weeks? What can they, what can you go to leadership and tell them?
We run through a library of about 300 to 500 measures, depending on the clinical program. We use a benchmark, and we're able, and since we have the cost accounting data from the hospitals, including all UCSF, for instance, we're able to not only look at the clinical endpoints and see where the gaps are in their clinical endpoints. So, looking at the root cause of, for instance, a bleeding event in a PCI, but we're also looking at the cost implications of that. So we list and rank what the opportunities are, both from a clinical and a financial perspective.
Okay. Let's give who else wants to run with that?
Can I go next?
You may.
Okay, thank you. So I mentioned briefly, like our first indication is ARDS, acute respiratory distress syndrome. Today, there is no FDA approved treatment for that. We are phase 2 ready. We hope to cross a major milestone between now and our presentation in Las Vegas, where we actually will be then dosing patients during this winter when we have high incidences of influenza. And just for contrast here, no therapy, 45% mortality rate. So that's what we are dealing against. So to answer your question more succinctly, our plan is to dose patients this winter.
Okay. So who else?
I'll go.
Yes, go.
I can go next in terms of, so we spent about so we had the luxury of starting out of Hopkins with 6 years of IP from the center I run at Hopkins, and then we spun out the company. We spent 1.5 years partnering with Epic and 1 year partnering with Cerner in order to make it very, very easy when we go to a new Cerner site or an Epic site to deploy our platform. And there are a number of things we did to make it easy. So the first one is leverage standard infrastructure that they have made available in order to embed. A lot of AI/ML solutions are often off the side. They're not within workflow, so providers don't want to use it. That was really crucial for us in our large prospective studies we did with 4,000 plus clinicians using our tool, showing 89% adoption. A big part of it was how it was embedded within workflow and deeply within workflow. Now, to get that deep level of embedding, if we go every system, and we had to intelligently design it so that like the integration cost for a new health system is really low. And so right now our system costs are basically, we ask for about 40 hours of IT tech time from them. It takes about 6 to 8 weeks for the system to go live. Most of the work is done by our team in cleaning up, testing. We require very little effort from the health system, partly because their IS teams are completely overwhelmed. We require 40 hours of time from them. We go in, integrate, and then go live. And then on the day we go live, we can start showing them insights. And the kinds of insights we show are today on your system, like we showed, for instance, a system we went live with. In 1 week, we showed them, here are of the patients that got transferred and escalated to the ICU. We flagged 60% of them. We flagged 60% of them with 1.5 day lead time. 30% of these patients died, which meant there was an opportunity if we were live in the front end, not just in the back end, for you to have flagged these patients, change their care, and reduce mortality, morbidity, length of stay.
Okay, great. Good. You answered the question. Does anyone else want to go up against that answer on the panel?
I'd say our learning. Sorry, go ahead.
Sorry, go ahead. No, I was just going to say there are two parts to it, the way I think about it, right? One is for sure, there's a need of hardcore clinical endpoints, what we need to demonstrate using clinical studies. But at the same time, being mindful about once the clinical endpoints are achieved, how are you seamlessly going to integrate this into the existing clinical workflow? So that becomes really, really critical, where you're seamlessly integrating for the champions of the department chairs, et cetera, where they have immediate real-time access to data, and you have clear indications like alerts generated for them so that they can be flagged, and much more personalized care can be provided just in time rather than delayed care being provided. But at the same time, also care escalation protocols. The way we work with health systems today is we design the care escalation protocols along with their clinical team so that once an alert is generated, it flags them and then the care is provided.
And do you have any of that data that like Sushi shared with, or is it too early?
Yeah, so we completed our clinical studies. We have some great results, not only on just cognitive endpoint, but also behavioral endpoints. We are going to present our results at Clinical Trials of Alzheimer's Association today and this month. So we'll be doing that.
Sanjay, I think you wanted to jump in.
Very fast. I would say that our key learning is we don't work with big hospitals and systems because we're working with Medicaid patients in primary care. So a lot of the folks we're working with are far less tech savvy or used to ML and quite skeptical of it. So they don't work at the speed of the archive lists, they work at the speed of trust. And in that context, we've found that hiding the machine learning behind our workforce and training our workforce to it and training a new workforce to it has been an important strategy for us. And as we now emerge out of our first year as a company, taking care of about 60,000 patients, we find that the significant RCT reduction in ER visits comes from essentially completely hiding the ML behind the existing workflows of our clinical staff.
That's awesome. And that's great. And given our timing, we're going to basically move on from this panel. And I just wanted to thank all of you guys. This is a great group of rising stars. This, new health application AI, it took us a lot to figure out this category. It's sort of horizontal and vertical at the same time. But look, if only half of you have half the basically success that we're looking at, we are going to all change the face of healthcare. Thanks, guys, and we'll see you in Vegas.
Thank you, Mark.
Thank you.
Bye.
And so next up is we're going to switch gears a little bit, and we're going to be talking about new EHR innovations. The electronic health record systems have opened up, creating incredible new opportunities for companies to basically append, extract, and build on all this data that was just flying around or basically sequestered in the back in someone's closet. We have two categories here. We have the best of class companies and we have the rising star companies. We're going to start with the best of class companies, and our four companies. The way the format's going to work for those just joining, each company will have 30 seconds to really give their elevator pitch. And then I'm going to basically throw a number of questions at them. And really with that, we're going to start with Benton from Arrive Health.
Yeah, thank you to USF and to the fellow finalists in our category. I think we have DNA shared with all of them, both with investors as well as our Explorers roots, Dr. Jane. So congratulations to everybody, and it's great to be here. Arrive Health is a patient-centric care access and affordability company. We have built, I think, the largest two-sided network. We have 150 million lives covered in terms of drug information and benefit information that we're integrating and providing to over 300,000 providers to make better prescribing decisions and help those patients save money to avoid those meds or meals conversations that we hear a lot about. We are in the process of approaching $5 billion in annual out-of-pocket spend flowing through our network. And in the last 3 years, we have grown from having about 300 health systems in our network to over 2,200. So the company continues to scale. We're getting a lot of good tailwinds from CMS, and just affordability and cost transparency are just great wins that we were able to catch and grow the business and really provide some value back to the patients of the world.
Excellent. Thank you, Ben. Well, with that, we'll go to Innovacer, and we know Innovacer well. And Neil, take it away.
Great. Well, thank you. And thanks for the invitation. Well, good afternoon. I'm Dr. Neil Jain. I'm Chief Innovation Officer at Innovacer, a health-focused, cloud-agnostic, EHR-agnostic platform company. And we provide a clinical fabric to accelerate the digital transformation journeys that many of our clients need to be on, especially in this very challenging time. As a biomedical engineer, clinical informaticist, physician, and health IT innovator, I think one of the most incredible things about being part of this journey is seeing the response that our customers have had with the challenges. We provide a data activation platform. And why do we need a data activation platform in healthcare? Well, not a surprise to many of you, most of the healthcare data is disjointed. And despite some of the efforts we made in interoperability, it remains inactionable. So our data activation platform provides both interoperability across stakeholders, but also enterprise intraoperability across applications to really take advantage of the opportunity to put that data to use. everything from population health to CRM or PRM, depending on how you look at it, all the way to care management, and then looking at that data as a data exhaust for some net new knowledge discovery with our life sciences clients. So between providers and health plans and life sciences, we probably have well north of over 60 health system provider organizations involved in our program. And in many ways, we look at this digital transformation journey as being a very data-centric approach. But for Innovacer, it's how do we bring the learnings across the network of our organizations, and then really drive some of the need to go above and beyond the EHR. We think of the EHR as a first center of gravity, and we think of Innovacer as a second center of gravity to do all those use cases that require us to go outside the four walls of an EHR.
Okay, great. Thanks, really appreciate it. Next up is Be Well Connected Health, and Peter, take it away.
Great. Thank you, Mark. And I'll echo that. Thank you to UCSF as well as the other finalists. We're really excited to be here. Peter Beaumont, Chief Outcomes Officer at Be Well. And I think just quickly, Be Well is a connected health platform that uniquely combines unprecedented data interoperability with a delightful front-end experience. We know that prior to COVID, digital transformation was a priority for close to 80% of healthcare CEOs. That sense of urgency has only increased today with the market conditions that we're seeing. And our platform and expertise allow our clients to meet and accelerate their own transformation. Be Well is built on a foundation of real-time information authorized by consumers and integrated bidirectionally into today's key workflow systems like EHRs. Our configurable workflows leverage this data and empower providers to deliver personalized messaging all the way down to an N of 1 level without having to use their most precious resources, our doctors and nurses. In addition, our open API platform has the ability for fast onboarding of third parties and solution partners with recommendations for consumers to provide that support between doctors' visits, which we think is critical to allowing our clients to build out a lifetime of loyalty between our clients and the individuals and families that they actually serve.
Great. Okay, thanks, Peter. That was great. Fourth company is DexCare, and Derek. Let's hear about DexCare.
Thanks, Mark. Thanks, UCSF as well. Yeah, my name's Derek Street. I'm co-founder and CEO of DexCare. We're a spin out of Providence Health System. We're a data-driven intelligence company focused on 100% focused on improving access for everyone. Our core offering is a software platform that intelligently orchestrates both the demand and the supply or the resource side of healthcare for health systems. What that means is we've got three things that we do really well. We help make care much more discoverable to consumers at the places where they're spending their time online, which typically isn't within the walls of the digital walls of a health system. We then have technology that intelligently routes them to the safest and best care options. And then our capacity optimization and load leveling technology ensures that resources are automatically allocated when and where they could be most productively employed. And so we work with some of the largest health systems in the country and other leading centers, Kaiser, Mass General, Brigham, Providence, of course, CHN, a whole host of systems to ensure that the care is discoverable and that it's both discoverable and sustainable for their organizations and their capacity as well.
That's excellent. I've run a spin out before, and you have this. It's hard, but you have an incredible unfair advantage, and it sounds like
it helps a lot. Yeah. Unfair advantage is a very good way of saying it.
Yeah, which is great. Here's the question I'm going to pose to you, the four of you. I want to dig in on superpower, and so what I've heard a lot of. What I heard just now is great, but I want to get a little more specific. And I want to get specific. If you had 10 seconds with the CEO of one of the largest healthcare systems of all, I want to tell you what story could you tell them how you basically have saved one of your larger providers or payers money and how quickly it could get deployed. I want to just go right to that specific. And I want to start with Innovacer.
Sure. I would say it's all about actionable interoperability and intraoperability. How do we make sure all those silos of data that you're sitting on, that you're paying for, can be connected together to drive new results and make healthcare delivery, reimbursement, and
specifics. So give me the story. Like you saved Y dollars in the in the ER? Just give me that story.
We saved a very large health system somewhere in the Southwest, millions of dollars by bringing together various IT data silos together to drive operational efficiency. Data that, frankly, may have been unlooked at for months.
Okay, good. I'll take it. Be well. Why don't you answer the same question?
Yeah, sure. So I think from our perspective, it's a relentless commitment to simplifying healthcare experiences for our customers, consumers, right? While also delivering value on their journey towards digital transformation and value-based care. Specifically with our customers, we've been able to demonstrate not only administrative cost savings in the north of 40% through automation of self-service patient tools, integrated booking, and integrated provider data management services. But also with our employer customers, we've been able to demonstrate measurable, north of 15% reduction in PMPY, employer expenses from a healthcare perspective. So I think that's really what we're continually focused on is actually driving outcomes at speed for our customers today.
That's great. Benson, your turn.
Yeah, it's a multifaceted answer, but I'll try to be quick in the nature of the 10-second ask. But I would tell that health system executive that we are the only health system owned provider of pharmacy related cost transparency solutions in the market today. And we've offered over 35 million transactions, which are events to save their patients money.
Okay, so you've got tons of stories. Derek, you said you were touching on this, but I want to give us one or two specifics.
Yeah. We can go very specific. So 30% increase in net new patients into the health system, 85% commercially insured, reimbursing at 73% higher rates, 8x the initial visit revenue and downstream revenue within the first 90 days, and a 40% increase in capacity within your existing system and existing service lines. And we've been able to repeat that across multiple health systems.
All right, well, that's excellent. I love that answer. Okay, let's just keep going. So let's talk about Epic and Epic and Cerner and basically why today is this incredible opportunity exists, and why do we not have to worry about Epic and Cerner jumping all over what it is you do? We know they're the incredible frenemy. Who do I want to start with? I'll actually I'm going to let it be a scrum. Whoever wants to answer this first.
Sure. I mean, I can go first. Look, EHRs are a heavily regulated monster of an application that they have their place. They're a documentation and billing system, and their ability to innovate in a sustainable way incredibly quick, unlike the rest of us on this panel, is going to be challenged. They have to worry about a lot of things where we can actually move much more quickly. There are countless examples where we have a population health solution called and a care management solution called InCare. And you would argue that, well, every single person who's got an EHR with a care management solution should not be interested in what we have. But we have dozens of customers who will choose us because the EHR only has to be 75% good. But we have to have a better approach to it in order for our clients to want us to bring us in. So I think it's really about innovation at the edges, and then we don't have to be stifled by all the other components that the EHR vendors have to deal with. But Mark, I don't want us to say that we aren't worried about EHRs. We definitely are worried about the EHR vendors because they continue to swim upstream, but we're always going to be one step ahead of them.
Who else wants to take a go at this?
I can go ahead. I can go ahead and add a little bit to it. So I agree with all of that. And we certainly we respect the EMR, heavily integrate their source of truth for a lot of data. The reality is, though, as most of us know, a fraction of healthcare actually happens inside of the walls of the health system, digital or otherwise. A lot of healthcare, most of it happens outside. And in our world, where we're trying to understand consumer intent and motivation to match them with the right care and then optimize resource on the back end, we need to have visibility across all that capacity, across all that work. And there are things that happen outside the EMR that you need to have access to from a data standpoint to make that work well. Second, final point is particularly when you get on the discovery side. And most of the people in our company, where we come from e-commerce, MarTech, ad tech backgrounds, applying those techniques, technologies, tools, et cetera, to this space, that's just not the world that the EMR folks typically come from. That's a CRM world. That's a marketing world. That's just a different type of DNA, and we find that it's complementary to what the EMRs do well.
Right.
To piggyback on the complementary comment, because it's true. I mean, from high tech through meaningful use, even with recent legislation around mandatory cost transparency capabilities within the e-prescribing and other ordering workflows, that is where the spend is happening, is inside the EMR. So for us to really impact and help providers get their patients on the lowest cost therapy, it has to happen kind of in the office. And so, Epic with their payer platform, that is somewhat competitive to what we do, but they will never be able to move as quickly as we can as a small, digital health company who's really innovating on behalf of the patients and helping their providers. They just can't keep up with our pace, but we do see them as.
And I think I would add too, is in the way that we think about it really is that you are more than just your clinical data, right? The EMR is that provider focused workflow tool. But we know that there's, north of 60, 70 different places today that people are going out to aggregate their healthcare, their clinical, their social data from. And EMRs are not necessarily aggregators of that data or those solutions, nor are they working to present that in an easy to understand, meaningful way for consumers, and then also make that actionable. And I think that's really where we see our services as complementary to a lot of the core systems out there from Epic, Cerner, and others.
Great.
But that doesn't mean that we're not going to disrupt that EHR dominated workflow. That's the whole goal for us to be able to disrupt it.
Right. Good. I think we've heard a lot about this. We've clearly heard that you're flexible, you're focused on problems. It's not what they do. And look, so much of what you ending up delivering to your customers is so much more than just the EHR. Okay. I think we're good on that. So I've got one more set of questions we're gonna run around, which is okay. So which provider? I want to hear names from you guys. You guys are more mature companies. You have customers. Which provider? Basically, give me that provider payer story that is just the story that a judge wants to hear. Do it quickly.
I'm happy to start, Mark. So we love all our customers partner. One I'll highlight is our work with Kaiser Permanente. We do a bunch of different things with them, but the one I'll highlight is they leverage DexCare for access and then load leveling virtual and then soon to be in clinic appointments on a 50-state basis, right? So even as large as Kaiser is, they don't have providers in every single state. But we worked with them to figure out a way so that they had their folks credentialed in all states. DexCare provides the underlying platform. If there are places where there's offices, people can get access to care that way. If it's virtual, because there's not an office there, they can do it that way as well. And then we load balance and load level across that entire network. So now we've got a point where now Kaiser can literally service everybody everywhere. DexCare is powering that entire system and do it in a way that's sustainable for the organization as well, routing the top of license, making sure the right people are seeing the right folks. And they're not having to see it, and patients aren't having to see a Teladoc provider in a state that they're not in. They can see a Kaiser provider.
Great. That's great answer. Let's see. Let's hear it from Benton.
Yeah, I think, historically, those are two entities, the payers and the providers, that haven't had a whole lot of trust. I mean, they're being pushed together, I think, just due to the nature of cost increases in the industry. But, I would suggest that as formularies get more complex on the pharmacy side, the cognitive load for a provider to know what is covered by any given patient, it's impossible for them to keep up. So we don't see this as an us versus them scenario. We see this as taking information from one side of that equation around coverage and cost information and getting it to providers when it's actually needed and actionable. Now that leads to positive outcomes on the health system side with prior auth avoidance, with managing step therapy, quantity limits, and other restrictions. But that information just can't happen in the old way of doing business, the old formulary and benefit process that has been driving e-prescribing. It's broken. So that opened up a door for a player like us to come in and say, okay, payers, give us your information. We will get that to the people who need it when they need it, and your members and their patients will benefit.
And which payer is your sings your praises loudest?
Oh, we work with all the main PBMs. That's where the 150 million covered lives comes from.
Okay.
So if you name one, we are probably working with them. On the health system side, I mentioned that we're in 2,300, 2,200 hospitals right now, but you name it, we're there right now.
All right, easy way to answer that. Peter.
Sure. I would say, one of our key customers is MedStar Health. And we've been partnering with them for the past year plus on increasing access and making care making them easier to do business with from a patient and consumer perspective. And that includes rolling out convenient ways to book and schedule primary care, urgent care appointments, but also find the care they need, whether that's in a facility, in person, digitally, or in the home. And so I think that's one of sort of our great customer examples in an organization that we see also sort of pushing digital transformation forward faster than a lot of organizations today.
That's great. Well, we're going to end this. We're going to end this panel now to sort of stay on track. I think what everyone's seen is for mature, great companies making a difference today. In an area or a category that you couldn't even play in 5 or 6 years ago because you couldn't get the data. So it's super exciting. Wish you best of luck. We'll see you all in Las Vegas. And again, congratulations, and keep the good stuff going.
Thanks, Mark.
Thanks, Mark.
Okay, so we're now at our fourth panel today and I'm the fourth. So you are the last group, and so we are focusing on rising stars, and these are the rising stars in new EHR innovations. We have 7 truly great companies. I know a number of you personally and well. The way this works, 30 seconds to basically strut your stuff. What do you got? Why are you different? Give us your elevator pitch, and then I'm going to throw some questions at you. First up is AvoMD, and we've got Yair Saperstein. Take it away, Yair.
Hey, I'm Yair Saperstein. I'm co-founder and CEO of AvoMD. Background as a clinician, so internal medicine and clinical informatics. And the idea of AvoMD really was a personal one. It started because I was overwhelmed by all the tasks that I needed to do as a doctor, and figuring out with that how to incorporate evidence-based medicine so I can give the patients the right things that they need and generate notes and all of these things in one. And so, what we came up with is a way to really take clinical decision support, but reimagine it into something that works for clinicians in the workflow. And what we do is we have a no-code builder that allows for the content transformation in a way that can be localized, not just national, but can also be controlled by medical societies so that it at once has the right guidelines and evidence-based medicine, but in a form that actually speaks with the electronic health record inside or outside to always give patients the best care by arming the providers with the best tools.
Perfect. Great story. We're going to go to AWell Health, and Thomas, take it away.
Yeah, hi everybody. Can you hear me, by the way?
Yep.
Yes. So AWell is a local platform used by clinicians and product teams to design their clinical workflows and integrate those workflows into their tech stack. So the designing is something that is best explained by what one of our customers said. This is a surgeon who said that our AWell Studio is the fastest path from his clinical brain to an executable workflow. And that was a very big compliment for us. Because we believe that it's really what's living in the brain of clinicians, clinical operations, product people that should end up being embedded in the tech stacks. And so we effectively take away engineering from that equation. The result of that is automating routine clinical tasks, synchronizing data between systems over care settings. So not just within a health system, but also across the settings where the patients are delivering or getting care and even at their home. And also driving seamless coordination between the care teams and the patients. Our platform has seen about 150,000 patients, live patients until today, and it's growing rapidly in a wide array of medical conditions. And the results that our care teams have achieved are, in my mind, mind-blowing, such as 50% increase in capacity, 40% reduction in length of stay, 25% reduction in emergency room admissions, and one of the most important ones, a lung cancer team saw a 60% increase in survival rate at 1-year follow-up.
Excellent. Okay, great. Well, good luck. Keep it going. Next up is Enderman 7, and Bill, take it from here.
Hi, I'm Bill O'Farrell. I'm a recent entree into the Andaman 7 team. I'm brought on to sort of spread our wings in the United States. Andaman 7 is a Belgium-based company founded by Vincent Cunel. We'd like to think of what we have as a patient engagement platform. And the origin story of that is that Vincent is a leukemia survivor. His son, likewise, a cancer survivor. And footnote, I'm a cancer survivor. And Vincent initially set out, who's a very experienced and detailed and insightful software engineer, set out to create an app for him to be able to agglomerate all of his medical information, all the tests, et cetera, so he could take it from place to place without having to, sort of fill things out and get records, et cetera, in order to sort of diagnose and ultimately get a cure for this horrible malady he suffered. So there's a really personal part of that, but along the way also, and now increasingly, we've added an ePro, patient-reported outcome capability to this PHR, and really the idea here is to be able to enable caregivers, researchers, and the patients to be able to work together. And really, so we're looking to, as a patient-centric application that enables better research, faster clinical trials, and ultimately better cures for the patients.
Great. Well, good job. And I love it. Next up is Stephen Riley from Mednition, a company I've known for many, many years. Take it away, Steve.
Steve, you're on mute.
Oh, got to demute.
There we go. Mark, great to see you again. And again, everyone, great to meet you. I'm Steve Riley, CEO and co-founder of Mednition, where we accelerate clinical decision-making using trusted and transparent AI. We started Mednition after my daughter was misdiagnosed in an emergency room, which led to some severe complications from human error. She's okay now, but it was clear that the hardworking clinicians needed far greater support to deliver safe and effective patient care. We developed Kate's real-time guidance helps nurses get the right patient to the right care at the right time. And all this is done without any change to process and at the front door of the hospital, which is one of the most riskiest areas in a hospital. Kate's simple to use, is loved by clinicians in over 20 hospitals, and Kate sees over 750,000 patients a year.
Great. I love the story, how it's coming together. Next up, Andrew Lockhart from Fathom.
Hi, everyone. My name's Andrew. I'm the co-founder and CEO of Fathom. What we do at Fathom is we automate medical coding. For those not familiar, that's the process of codifying clinical documentation into the codes necessary for reimbursement. Our model, we take a deep learning approach, is now built on top of over 400 million coded encounters. We code roughly 10% of emergency department visits in the country, and that's just one of our specialties.
Okay, great. You're the only one who made it under 30 seconds. Wellbeam, that's awesome. Wellbeam, next up is Amy. Tell us about Wellbeam.
Hey, great to meet you guys. I'm Amy Devani, CEO, co-founder of Wellbeam. We're a digital healthcare platform that bridges clinical care workflows between acute and post-acute care settings. So physicians discharging patients, but continuing to oversee their care. We replace fax and phone tag. Yes, in 2022, still fax. We're a two-sided network model with health systems and post-acute partners that use our system. We are EMR agnostic. We support the reduction in reduced home health readmissions by providing higher touch points with clinical teams taking care of patients and the opportunity to bill for those workflows that currently under fax often go unbilled. We work with a number of large health systems. Excited to meet everyone.
Great, thanks, Amy. Next up, we got Particle Health and Steve Swank, take it away.
Yeah, Particle Health. Hey, I'm Steve. I'm the Chief Revenue Officer of Particle. We are a company, we have an API that sits on top of the three major networks in the US, Care Quality, Commonwealth, eHealth Exchange. And what we do is we access clinical data at scale for digital health companies. So we basically take in basic demographic information from our clients. We go out to those networks, ping the networks, and under the treatment use case comes back. We have a hit rate of 90% of the time. We find records on the patients, about 105 records per patient. And all that data is brought back in CCDA. We convert that into FHIR R4, and then we make that available to our clients. So ultimately, we see ourselves as powering a lot of the digital health companies that we've heard from today. That is our primary market segment. As it relates to the EHR, you might be wondering why we're doing this. We just launched a platform for EHRs, so EHRs can sell through our data to their downstream customers. And so just happy to be here. We're excited to help power digital health in the future and help a lot of the upstarts that are here today and out in the world, you know, make a difference in the world and make it possible to provide care, because you need data to provide care.
Excellent. Thanks, Steve. Particle Story is just, again, been following it for years, and, you know, it's getting better and better and better. Okay, so the big question I'm going to ask the seven of you, and I'm going to let it, we sort of had more fun with a scrum here. I'm not going to even, I'm going to let you jump in. Who is solving, which of you is solving a multi-billion-dollar problem? And why should, and why should the judges vote for you? Like, why you? Why should you win? The billion-dollar, the big problem. If you don't think you're solving that multi-billion-dollar problem, you don't have to answer this. But I'll let you, whoever wants to go first, go.
All right, I'll start. So high level, over $15 billion is spent every year on medical coding just in the United States alone. If you want to ground that to real business economics, the revenue run rate of 3M's coding support software is $1.2 billion a year. And that's helping to do the work. Fathom does the work.
Okay, that works. Who's next?
I can go. Sorry.
Go for it, Thomas.
Yeah, thanks, Yair. So coming back to what I said in the beginning, so when I see that our customers achieve results like 40% reductions in length of stay, 25% reduction in emergency room, and that's just I mean that's just the couple dozen customers that we are serving. This is a testimony to, you know, the opportunity that lies out there to cut waste from the system and to gain or to save those billions for society, basically. And if we and so we are obviously taking part of the value that we create. So that's why we're creating a multi-billion-dollar company.
Great.
And I'll go next, kind of bouncing off of that. If you take any of the chronic conditions where the majority of money is spent on people in the end of their life, if you can control chronic conditions in a way that's effective, then you win. And because controlling it depends on the way that decisions are made and clinical decision support, by creating the best clinical decision support in a way that does apply to local-based care, then you solve the billion-dollar question or multi-billion-dollar question, and we have the best solution for it because it can be customized and work best for engagement with clinicians at the point of care.
I'll go next. 150 million people approximately go to the emergency room every year in the US. 70% of all admitted patients come through the ED. We're right at the front door. So as hospitals struggle with staffing, rising costs, and patient risk, we can read the entire medical record, including free text. From that, obviously develop highly accurate ML models, and then apply that back to the clinicians while the patient is still in front of them. And if you can put a patient on the best possible pathway right at launch, everything gets better. You know, the nurses, they're more happy and they feel supported. So do the clinicians. We're seeing sepsis at the door, 7 in 10, 9 in 10 without labs. So when you can do that with a patient, everything gets better, including reimbursements all the way downstream. So
happy to jump in. So just to add to that, I think all of that resonates very strongly as well. A quarter of patients go home with home health care, and yet physicians will say they do these complex cases within the four walls of a health system. Maybe it's a pancreatic surgery and provided best-in-class care, but the issue is really what happens after that. Providence Health lost $60 million last year from readmissions from home health. And that really is the bridge that we bridge and the gap where patients can come back as readmissions that Wellbeam tackles.
I'll
close it out if that's all right, or I don't know if there's anyone else, but
I'd have something to add after you, please.
All right, let's go. It's all good.
all right, so just real quick, US healthcare system is 20% of our GDP. There's a lot of just really old staid players that have been around forever. Last year, there were 850 digital health companies funded to the tune of $44 billion. Every single person on the phone today is starting a new digital health company that's trying to disrupt that. And what Particle does is we're ultimately there to provide the data to all the companies here and all the other folks to allow you to do what you do, but do it better, because you can't do it without the data. And so that would be my pitch for why we can be a multi-billion-dollar company. As long as we feel that transformation will continue to happen within healthcare. Every single company on this call is a potential client of ours, and there are lots of other use cases even outside of the ultimate healthcare environment with individual access and other things coming online.
That's great. So you guys are...
I would just quickly throw in, I think every single one of the companies on this call right now is $1 billion opportunity and $1 billion company. And there's so many places, every single one of the places, each one of our panelists identified, there's waste, there's inefficiencies, there's opportunity, and there's changes in regulations, and there's changes in attitudes. Ours is particularly getting patient information more quickly to the places that can use it more effectively in real world outcomes for better outcomes.
No, I think this category, again, we had a little challenges naming it new EHR innovation, but this is at the core of everything. If we want to basically get the savings, we want the savings to happen in healthcare. It's going to start with where the data is and where the patient information is, and it's what you companies can do by basically taking it away from the traditional EHR vendors. I've got we've got a few more minutes, so I've got one more question for everyone, and it's going to come down to specifics. And I want to hear the specific story, one story, and I'll let it get out there, make it a scrum. Give me a story of a specific provider or a specific payer or a specific pharma that's basically used your solution and you've been a game changer.
I'll go. So we have one of our clients they're focused on managing ESRD populations. They have 150,000 patients. If we are able to drive, and the early data shows that we are able to drive that, if we can drive 2% of that population, which is about 3,000 patients, and reduce readmission for that one patient one time a year, depending on what you value, like that readmission, you could hear numbers from $1,000 to tens of thousands of dollars, depending on what that looks like. I mean, that's a savings of $10 to $20 million a year for that one company. So that's one example. We're proving that out. That's going to be our very first real use case, but that's where the data is showing it. So.
Great. I'll take it. Who's next?
Happy to go next. Dell Medical had about 375 providers that had to deal with different internal medicine conditions in the inpatient setting. One of them in particular is COVID. COVID comes and goes, and what they found is that their providers were trying to sort through their 30-page guideline of what to actually do with COVID in a way that constantly changed, and their providers were not quite doing the standard. They implemented that guideline using our no-code builder into AvoMD that had a link from the EHR, and found that their providers, 99% of them were using it, that there was a 54% efficiency gain, and that there was standardization not just of treatment, but also of documentation.
I'll take it. Who's next?
Happy to go.
Go ahead, Amy.
Okay, thank you. So we've been live with Stanford Healthcare for 2 years. It's used by about 500 physicians and their teams across Stanford Healthcare. It's used really as their transition of care. So it gives providers visibility into where their patients are going after discharge, what their status is with home health. So have they been readmitted? Has their length of service been extended? It gives them a touch point with their clinicians at the bedside with those patients. So where conditions are deteriorating, it allows clinicians to communicate real time to avoid wound issues and readmissions. So overall, we've been able to, with an IRB clinical study that has been completed, reduced readmissions by 25% from home health. We've been able to give back 3 to 5 hours per patient case to providers of work done after work, spent creating manual encounters, and we've put green dollar value back into Stanford Healthcare by being able to automate the charge code capture from a series of CMS G codes.
Awesome.
All right, thanks. I'll approach it from two perspectives. One of our sites, Adventist Health White Memorial, where we first implemented Kate, actually used Kate in their Malcolm Baldrige submission, which they won. And not only was the ROI 10x, but it made such a meaningful difference to them in achieving the quadruple aim that Kate became the standard of care through the entire Adventist health system. On an individual basis, I was in the ED one day and Kate alerted on sepsis for a particular patient. That patient ultimately had a pretty tough outcome, but he lived, and it was because of that we gave them the best opportunity to get the antibiotics on early and get them up to the ICU. And that really kind of drove the rollout through Adventist Health, so much so that they recently presented their results across a number of sites with Sepsis Alliance. So we're really proud of the results that we're bringing to the people who are relying on Kate to be accurate, and then the patients that they're caring for.
Great.
Our biggest success story, our partner has to remain nameless because we're still under NDA, but it is a very, very large pharma. And it's being deployed to pilot the collection of real world evidence on a longitudinal basis for over-the-counter products and consumer products, which we think is an important component to not only being able to provide sort of better advice and better direction for these products, but also for the longer run to really be able to detect potential problems, and for the companies themselves avoid some lawsuits, and obviously for the patients and the consumers avoid bad outcomes.
That works.
Okay, I think I'm last to go. So about a year ago, one of our customers, which is a large regional hospital in Europe, their lung cancer team published in the Lung Cancer Journal about data that they achieved together with our platform. And what was surprising is that with one, let's say, holistic lung cancer care pathway, they were able to improve on outcomes, so both 25% in ER admission reductions, as well as that 60% higher survival at 1 year follow-up, which I mentioned before, but also not unimportantly, a 40% increase in capacity at their day clinic. So showing that just one holistically well-designed, well-implemented care pathway can really deliver on both efficiency and outcomes improvements.
That's great.
And sorry, I didn't get a chance to get. So what I want to talk about was, so the emergency center, they run the standalone ED clinics for Dignity Health. Their entire rev cycle was in complete disarray due to staff turnover. So they were now a month and a half behind. When they reached out to us, we were able to go through contracting and deploy in 7 weeks. On the day we deployed, we coded 17,000 encounters that had been sitting there in backlog. And what that allowed them to do is, one, get those claims out the door so they could get reimbursed. They were having trouble making ends meet. Second, what they saw is basically a massive increase in RVUs, so mapping to roughly 10%. And then on top of it, on the back end, is they were seeing a huge decrease in overall denials by about 3%.
Good. That's a great stories. I think everyone's gone here. So I'm going to close it out. This came in the, can you see the trophy? Isn't that great? It came in the mail just now. You guys are going to win trophies, hopefully. And but this has been this panel is a great panel. This is I actually think this award is it's representative of all of you companies are going. This is where the core of the transformation is in digital health. In Las Vegas in 2 weeks, one of you is, or actually a number of you are going to be rising stars, and it's the beginning of what's going to be an amazing journey for all of you. Thank you for the time. This has been a great panel. You've got fantastic stories, and again, we'll see you at Health. Got a few judges that are still judging away, and they're going to be able to take advantage of this. So thanks again, everyone. Have a great rest of your day, and see you in Vegas.